Good afternoon. I first would like to thank the American College of Cardiology and the Argentine Cardiology Society and the Argentine Federation of Cardiology for allowing me to present this afternoon, to share this moment with all of you here present and those who are connected through the web. I will refer to some brief issues related to epidemiology and how to face the huge cardiometabolic epidemic that we are undergoing in our country. This slide shows comparisons. This was published in the New England Journal of Medicine in 2017, comparing 1990s and 2015 for different risk factors and that are attributable to obesity, and you can see how most of them have doubled in 25 years, and it has also doubled in, you see it in purple, especially deaths caused by diabetes. And here we are just talking about overweight and obesity. In both cases, we are comparing 1990 and 2015. One of the last epidemiologic studies was InterHeart, which was a sub-study for Latin America, InterHeart LATAM, that showed a huge prevalence of abdominal obesity in the Latin American region. Dr. Ledman has already showed you data from the Risk Factor National Survey, and I will insist on this because we have a real problem with obesity. But the InterHeart LATAM, Argentina, Brazil, Colombia, Chile, Guatemala, and Mexico, the populational risk attributable to abdominal obesity is of almost 46%. And this study also showed with a high level of certainty how lipidemia, in this case measured through the APUB and APUA, a very fine measure to measure alteration in lipids in the blood, was the second factor in the Latin American region with a populational risk of approximately 40%. We were just saying that the national survey, the National Risk Factor Survey, is something that really makes us proud. And as Dr. Lerman has shown, we see data for the last decade, but I want to insist on the prevalence of overweight and obesity, which has increased by 34% in just 10 years. Out of every 10 Argentines are overweight, and obesity increased 42%. So this is alarming, and we can even say that 2 out of 10 Argentines are obese. Obesity and overweight, this includes 6 out of every 10 Argentines. And in hand with this, of course, we have an increase in the prevalence of diabetes by 17%. This was also shown by Dr. Lerman. But this shows that the public health issue that we are experiencing in Argentina has to do with obesity and dyslipidemia associated to obesity, which is the metabolic obesity and metabolic dyslipidemia, and we are seeing patients that are more and more suffering diabetes. And this is the acute myocardium infarction national survey by the Argentine Society of Cardiology and the Argentine Federation of Cardiology that shows data that most who suffer infarctions are men, but the relationship between the acute myocardium infarction with risk factors which are prevalent, such as hypertension, smoking, and also dyslipidemia and diabetes. That is to say, we need to modify some guidelines in our country if we want to reduce, if we really want to reduce this cardiovascular mortality. And the thing is how we can take this knowledge, this cardiovascular knowledge into practice, and who are identify patients who are at risk with an increase in very major risk factors such as hypercholesterolemia, inherited or familial hyperhysterolemia. You know that this is subdiagnosed and subtreated. Unfortunately, the populational frequency is 1 in 50 or 1 in 500. But we have these patients, everyday patients with abdominal obesity with an LDL that is not very high usually, and it's 1 out of every 5 patients that comes into our ward are characterized by high triglycerides and LDL also that's around 190, and other characteristics that represent metabolic syndrome. And this, of course, has a huge importance from the risk factor viewpoint. If we compare 2 males with the same age and the same LDL of 90 milligrams per deciliters, the one on the left has a low HDLS, it doesn't smoke, and no familial history. Well, these are the distinctive elements in a risk calculator such as a renal. But the important thing here is that the patient on the left has a 5-year risk of only 2%, and we should treat 125 patients in order to avoid 1 myocardium infarction. And on the right, the risk is 4 times higher, and by just treating 25 patients, we will be able to avoid 1 myocardium infarction. Dyslipidemia is very prevalent. We have a confluence of environmental risks, inflammation, genetic factors, social, cultural, and economic conditions. This is metabolic syndrome, atherogenic dyslipidemia, and the atherosclerosis disease. This is hugely prevalent in the group of patients that have diabetes or that have metabolic syndrome. 1/4 of the patients that have some sort of condition have metabolic dyslipidemia. The metabolic dyslipidemia has very distinct characteristics, which are known in general terms, but not in detail. So we need to know that we are talking about insulin resistance in pre-diabetic patients with a large flow of fatty acids, a lot of VLDL enriched with triglycerides and APB and APOB, and the VLDL provide triglycerides to the LDLs, and they are lost through the kidneys, and the LDLs receive the TGLs, and they generate the small LDLs and the thick ones, which are oxidable and iatrogenic. And under this context, that justifies the reason why patients with cardiometabolic risk have a lot of qualitative and quantitative alterations, but they are characterized by a large production of VLDL, and they may not be increased but they have the predomination of the small ones, and of course the HDLs are normal and they have more catabolism. The important thing is to set on the same footing this type of dyslipidemias together with hypercholesterolemia, isolated one, because they're not only capable of generating atherosclerosis, but also the remnants, which are cholesterol-rich particles and small, they go through the subendothelium, and we can say that the remnant lipoproteins that contain APOB are metabolically distinct from LDL, but they have emerged as a new way of atherosclerosis. And we have the TGs, because TGs And genetic studies have shown us that the TGs constitute a risk-related factor. You can see how an increase of a standard deviation in individuals that have genetic variables that determine the increase of the LDL cholesterol, they increase the risk of infarction. This does not happen when there is an increase in the LDL cholesterol standard deviation, but it does happen when there is an increase in the standard deviation of TGs in those patients with familial genetic incidence. And in practice, what can we use in order to identify these types of patients? We have the different scores, the Framingham, the European score, very popular in Argentina, Reynolds, or the World Health Organization recommended by the Health Ministry. And also many physicians are using the ACC risk calculator because it has other possibilities such as including the LDL cholesterol and calculate the long-term risk. I think that this is stuck. Excuse me. Okay, now I will briefly show you the different guides. We were talking with some of the authors recently. Pam was part of them, and they stopped putting emphasis on lipidic goals with a lot of controversy, but they have also taught physicians to better treat our patients who are considered risk patients. And you can see in primary prevention, we have 3 groups with a high evidence to be treated with statins. You are familiar with this, but this is what the American guide says. The European standards keep the lipidic goals in very high-risk patients. And an interesting thing is that you need to recall that the European guides say that moderate or low-risk patients in LDL cholesterol should be less than 115, and the European guides have included some items that include more risk for our patients. For example, a diabetic patient with proteinuria is of high risk or very high risk. So these are interesting issues to consider. And regarding our own country, we have 3 guides: the Argentine Federation of Cardiology guide, the Cardiology Society guide, and the Lipid Society guide. Unfortunately, we weren't able to have just one single guide for our country, but in general terms, they coincide, and we maintain the classic lipidic goals, except for the last one in the Lipids Society, and they talk about an LDL that's less than 50 for some specific very high-risk patients. Now, considering the therapies and treatments, to conclude, I will present briefly a study that I believe it's worthwhile knowing. This is the stability sub-study for secondary prevention in 1,200 patients, 12,000 patients with a Mediterranean diet. You cannot see the lower line, but the yellow is a score of less than 10%, quite low, and the ideal would be to have over 30%, such as some countries have in green. But Argentina, you can see that the score for Mediterranean diet, fruit and fish consumption and vegetables consumption is quite low, and this correlates to the higher risk that we have in myocardium infarction. And this green line shows patients that have less MIs, but they have Mediterranean diet that's 12 points over, but we are below in Argentina, below the 10 points. So we really need to modify our diet or nutrition guidelines. Regarding metabolic issues, well, my colleagues will talk about this. And regarding statins, for vascular events in diabetics, they are the first option for the standard treatment. We can add, this is a sub-study, the IMPROVE sub-study, the first one with ezetimibe that showed benefits in patients for secondary prevention. Nowadays, we're talking about today we're talking about primary prevention, but we can extrapolate these results. But patients with metabolic risk and diabetes risk are the ones who benefit the most with ezetimibe, and also the PCSK9 inhibition effects alirocumab on the atherogenic dyslipidemia? Well, this is simply to show you the benefits in this case. This is alirocumab in atherogenic dyslipidemia, as I said, reducing the LDL cholesterol over 40% and also the proportion of LDL which are small and dense. So this, the therapeutic armamentarium for atherogenic dyslipidemia is larger and larger. We have management of TGs and fibrates. You know that there is no sufficient evidence with fibrates, but the bars in yellow show that patients that in all these studies that you're familiar with, these last ones, even the fibrate was added to the statins. The ones who had high TGs were really benefited, but nowadays we are waiting for the results of other ongoing studies with omega-3, like REDUCE-IT, and the prominent one with fibrates. But of course, we need to have further evidence on whether TGs, he corrects himself, fibrates are effective to treat TGs, which are constantly elevated in these kinds of patients. The presence of elevated cardiovascular risk is a common situation in our clinical practice in Argentina. The ID and treatments of dyslipidemia is essential to reduce the elevated and unacceptable morbid mortality in cardiovascular cases. Atherogenic dyslipidemia implies deep qualitative and quantitative of blood lipids. The change in the lifestyle is essential in order to approach cardiometabolic risk. The control of LDL is, of course, the priority, treating them with statins in adequate doses in virtue of the patient's risk, and beyond the use of statins, if it was necessary, we can, in primary prevention, add ezetimibe or eventually the PCSK9 inhibitors. And although we need more evidence, the fibrates and omega-3 can be considered when TGs are persistently elevated in these types of patients. Thank you very much.